Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hey listeners, I value you being here. Please, I encourage you to leave a review. I'm going to be reading out a review each month, and that person can have a one-on-one call with me to have a chat. And I think that is a great way to reward you as a listener. Also, as you like and subscribe to this podcast, it helps get our message out to other physicians and clinicians who are struggling. Thank you so much for your reviews, and I look forward to reading them out here on the podcast. Hello, everybody, and welcome back to another episode. I am excited to have Dr. Paul DeChant with us today to talk about his experience in medicine and the things he's doing now. Welcome.
Hi, Sarah. So glad to be here.
Nice to have you. Please introduce yourself. Tell us about you and your work in the world.
Okay, thank you. So family medicine practiced for 25 years in various settings and health systems around the country, some large groups, some very small groups. Over the course of those 25 years, I could never keep my mouth shut when things didn't go right in my office, so I spoke up, and that got me put onto committees and then into medical director roles, and ultimately I became the CEO of a 300 physician group in Modesto, California, the Sutter Gould Medical Foundation. During that time, I led a transformation in the group around the theme of returning joy to patient care. And the way we did this, people sometimes are surprised, is we focused on lean as the process by which we were going to do this work. And I was drawn to lean not because of the process of the improvement in practice efficiency, which we all need and which is vitally important, but because of the first principle of lean that this group we worked with espoused, which is respect for people, meaning that respect everybody, recognizing that everyone, and particularly physicians, and these days anybody working in a healthcare setting, is a knowledge worker. And as opposed to the traditional old top-down management, control and command management. And that respect for people concept resonated deeply with me. And so as we brought that into play, along with then the traditional lean ways to remove waste and improve efficiency, we were able to achieve a lot. By the end of the 5 years I was CEO, we actually had improved to the point where we got recognized as the top performer among 170 medical groups across the state of California 2 years in a row. And our physician satisfaction improved dramatically. We went from the 45th up to the 87th percentile on physician satisfaction. So we knew we were doing something right. And from there, I then went into coaching and consulting, first with the lean firm that I'd hired and working with major health systems around the country, helping their leadership teams to do this work. Our group got acquired into IBM Watson Health specifically, back in the day when people were very excited about the early AI and Watson as a way to help fix healthcare. And was working on ambient AI systems and the whole gamut. But about 5 years in with that, it started to feel a little too corporate, and I ended up going out on my own. I've got one partner in a small LLC, and then I do a lot of work on my own. Still coaching and consulting with health system leaders, do a lot of keynote speaking and writing blogs, writing a book. I don't know, you may have featured this book. One of my co-author was on, this is Preventing Physician Burnout, Curing the Chaos, Returning Joy to Patient Care. Diane Shannon was one of your earlier guests, and she was my co-author. I was very fortunate to work with her in writing the book. I now actually am working part-time, 0.2 FTE, with the AMA in their work on reducing physician burnout. They call it PS2, professional satisfaction and practice sustainment. And the AMA has committed a significant amount of resource to this, and it's a real pleasure to be working with them as well.
There you go. So it's all up our lane of creating some sustainability. So I love this.
Yeah.
So good. So tell us, what would it have looked like to be a physician at the Sutter Gold before you started working with them? and then 5 years later. So what is the difference for the physician on the ground in that organization? What changed?
I think the thing that really changed, the way I describe it is, for the 25 years I practiced as a family doc, every day I was slowly burning out and craving the autonomy to fix what was wrong in my office. Then I became the CEO, and like many CEOs, they think we want to empower people, but the thought of 300 doctors all independently, autonomously empowered to fix things the way they wanted scared me that we could fall apart from entropy. And
Mhm.
so I knew if and we were in trouble financially at the time. This was 2009. It was the
Mhm.
depths of the Great Recession. We were $9 million in the hole when I took over. Our county had 18% unemployment, and things were grim, and the pressure on me to turn it around quickly was intense. And I was tempted to become that top-down micromanager, go tell all the doctors they needed to cut back, have shorter intervals, improve productivity by 10%. I don't care how you do it, just do it. But I knew it might work in the short run, but it wasn't going to work in the long run. So instead,
Mhm.
we really looked at and learned how to give people the autonomy to fix what was wrong in their office, in their locale. That local autonomy. I'm going to describe it as acting locally and thinking globally. So acting locally, we train people how to do good problem solving and encourage them to do that in their offices. And then acting globally or thinking globally, we aligned everyone around the shared values that bring meaning to our work. And the way we did that was when we look at almost every health system, there's a system dashboard with 5 or 6 metrics on it that everybody's pursuing. And those are outcome metrics. And ideally, we can see that there's a connection between the values that drew us to medicine and the metrics that we're trying to improve our performance on. At the local level, where the docs and nurses and staff are working, we those outcome metrics don't mean much because they happen so far down the line, but process metrics can mean a lot. And so thinking about the processes you need to do in order to improve productivity without adding burden, or to improve the interaction with the patient to create a better patient satisfaction score, or any of the other number of metrics that we follow, we can clearly see process metrics in the offices that they have control over. They can work on those, and we can motivate, we build in systems to help motivate that work. And people feel good about it when they do it. Who wouldn't want to feel better about the way their patient's being cared for and the like. So we looked at, we empowered people, took the chance on autonomy locally, but aligned everyone and reduced the risk of that entropy by aligning around those values that bring meaning to our work, and making it very clear how the metrics that we pursued worked there.
Okay, what were some of the metrics that the local physicians were asked to concentrate on when they're looking to lean their practice and improve efficiency locally?
Yeah. So leaning the practice. The other problem with lean is it scares people. They think, oh my God, you're just going to make me work harder and faster. And I don't believe all this crap about work smarter, not harder. Or it means you're going to cut my staff and cut my resources. And,
That's right.
you know, and when people do lean wrong, that happens. But when
Mm.
people do lean right, it doesn't, because there is so much that needs to get done. If we can find a way to do something more efficiently, like for example, one of the first major redesigns we did was the front desk in the internal medicine clinic. There were
Mhm.
18 doctors on the floor. We had 9 people working at the front desk checking people in, and we looked at every step in the process and realized so much of it truly was wasteful. Some of it had just evolved that way over time as things had changed. Technology had improved, but we hadn't really introduced it yet, things like that. After a week of redesign, we only needed 6 people at the front desk to check the patients in more quickly, more accurately, and in a more warm and friendly manner. So we had 3 extra people who we quotes didn't need, but we only didn't need them at the front desk of internal medicine. We still needed people to staff front desk and other clinics. We needed people to help run a revenue cycle. We needed people to help us with this lean improvement work. There's always ways to redeploy people into something that's interesting work for them. So it's not, the idea wasn't to just cut people. The idea is to find ways where we can actually produce more without working harder, and in the process, just use our people more effectively. So we were actually over time able to grow from 300 physicians to 400 physicians. But initially we had about 1,050 staff members. And by the end of that 5 years, we had 400 physicians, but we'd only added 50 more staff members because we were able to reduce the wasteful time that the staff were spending doing other things.
Okay, so it's helping each person in their role be more top of scope, doing things that they're interested in doing meaningful work, stopping the work that's no longer required, really looking at that process.
Yeah, even the AMA has an acronym for this now. It's called Getting Rid of Stupid Stuff, or GROSS, GROSS. And the whole concept is to either, we all know this stuff that we know there's a better way. We just rarely get the opportunity to actually make it happen. And by putting into place, leaders who are committed to it, empowering the people who want to do it. And so it happens at a macro level, like at the workflow through an entire clinic, but it also happens in micro levels. At a physician working with their support person, and realizing we don't have to go through. There's these steps we just don't need to do, and we still get the work done. Or if we just moved, one of the doctors started sitting next to his nurse during lunch and in breaks, rather than going back to his private office. And in doing that, he cut down the number of emails back and forth in the EHR, because they could just talk to each other about a question about a patient instead of having to email each other back and forth. And they always knew what was going on. And if they needed something quickly, they just jumped up and did it. So there's micro things we can do as well as macro things and some of it's not obvious at first. One of the other things in that big office, this was a brand new building when I got there. They had just designed it, just built it, and it almost could not have been worse designed from a lean and efficiency standpoint. I remember going into the hallways, it was like a maze. I was afraid I would get lost. And in fact, patients frequently stopped the staff to ask, how do I get out of here after they finish their visit? So we just put arrows on the floor that pointed the way out. And in one day, 90% of the interruptions that the staff had were gone. But we also realized that the older doctors who'd been there the longest had the most seniority and, deserved the best offices. The corner office, those offices were the farthest from the waiting room. And they had the oldest patients. To get there. And once we mapped it all out for them and showed it to them, they said, my gosh, no wonder I'm running behind all the time. We're wasting 10 minutes of my nurse's time and the patient's time just walking through the hallway. I want to move up to the front by the waiting room. My slower moving patients can get in 3 minutes, 4 minutes faster each. Heck, that saves me an hour each day right there. It's really just stepping back and analyzing things like this that make a difference. But the big focus to reduce burnout is to recognize that the problem with burnout, it's the workplace. It's not the workers. And that's, I think, a message that people now get it. But 10 years ago, when I started doing the consulting, and 15, 20 years ago, when I was really, working as a doc and then leading, most people didn't understand that. So much of our emphasis was on enhancing resilience. And that's still necessary, but we can reduce the need for resilience by making things more easier, working better, and then building a more positive culture in the organization as well.
Yeah. Okay. That makes so much sense. I'm glad somebody's making some sense in this particular aspect of medicine, because you're right. The the staff were given, the workplace design, the building design, the types of things we're asked to do all contribute to your fatigue, your executive function load, your number of interruptions, like you said.
Yeah. Yeah. One of the fortunate things I've been able to do is I've gotten to know Christina Maslock very well, who's well known for the Maslock Burnout Inventory. And in getting to know her, she and her co-researcher identified the three dimensions of burnout: exhaustion, cynicism, and inefficacy. Exhaustion being we've worked so hard, we're just completely depleted, we have nothing left to give.
Yes.
And the cynicism, now you recognize it kind of comes in part naturally as a self-protective mechanism, because you just need it. So you start to protect yourself from your patients, from your colleagues, from the organization. And then when you're exhausted and cynical, you start to wonder if you're making any difference at all. It's that sense of inefficacy. But what was really cool about what Maslow and Leiter found, in addition, they identified 6 drivers that linked to those dimensions of burnout. And the first one is work overload, which they showed drives exhaustion.
Yes.
And that's no huge revelation. I don't think anybody needed a research grant to figure that one out.
Yes.
But the problem is most people stop there. They think that's burnout. I'm overloaded and I'm exhausted.
Yeah.
What can I do? I can just reduce my work burden, which most people think means I need to see less patients. But we can if we redesign work, we actually can reduce the burden without having to reduce the volume of care we're giving. And secondly, but still people aren't thinking through, there's these 5 other drivers that they identified. The next one being a lack of control. And control, that autonomy, is so important to us. And we know there's things that need to get fixed and we're just not allowed to fix them. It drives you crazy. The next is insufficient recognition or reward and appreciation. We work so hard, we do amazing things, we save lives, and oftentimes the level of appreciation for the amazing work we do, we just don't get to feel it or hear it every day to the level that we really deserve. And boy, that can sure help you get through a tough time better when somebody acknowledges or recognizes and appreciates you. After that, the next driver is breakdown of community, collegiality, and connection. And during the pandemic, that was huge. But even now, I see so many times I'm in a room where there's a group of people together, but people are spending as much or more time with their devices than they are with each other, because we get so caught up in that. The next driver that they identified was absence of fairness, which I really think are 2 levels. One is there's a macro level, the job that we signed up to do back when we were bright, young, idealistic pre-meds, that's not what we're doing. It's been a huge bait and switch. At least it feels like it, like somebody's manipulating the universe and bait and switched us. It wasn't any one person, I don't think. But it's real, that feeling that it's just not fair. And then there's the micro level of unfairness, where your opportunities are limited, not based on the quality of your contribution, but on things you don't have any control over, like gender, race, country of origin, age, or sexual orientation. It's that, which is really, and it just eats at your soul. And then lastly is values conflict, when the deeply held personal values you have are not aligned with those of your organization, or you have to participate or even observe things that violate your values, which again happened a lot during the pandemic, when we were helpless to really, so many times we knew what we needed to do, we didn't have the ability to do it. And in particular the absence of fairness and the values conflicts really are key drivers of moral injury. People talk a lot about moral injury these days.
Yeah.
And there's some debate about, is moral injury different than burnout or the same? I personally believe first of all, I believe it's not worth having that debate, because moral injury is tied to absence of fairness and values conflicts. And we all need to be working together on this rather than trying to put up some artificial barriers. But secondly, we come to realize that these other 5 drivers I just described, the control, reward, community, fairness, and values, they have everything to do with how someone leads or manages. Whether you're leading a small team of 2 or 3 people, or a CEO of an organization with 20 or 30,000 employees, when you lead in a way that exacerbates those drivers, that makes them worse, Maslow and Leiter showed that drives cynicism. And when we lead in a way that empowers people and aligns them, then we actually drive great engagement. It's the opposite. It's the antidote to cynicism. And as this started to become clear that we have this opportunity to reduce work overload and to lead in a different way, there is a pathway that we have to truly make a difference. One of the biggest challenges now is connecting frontline clinicians and leaders in the C-suite, because so many leaders in the C-suite have, for whatever multiple reasons, good and some not so good, have really gotten disconnected from the realities of the front line. And so there's this deep distrust and disrespect in many organizations between the senior leaders and the frontline clinicians. And we need those both stakeholders to be working together to solve these problems, because they're big, hairy problems that we need to solve. So a lot of my focus now, having been both a frontline clinician and a CEO, is to help senior leaders reconnect with frontline physicians and understand what's going on. Because many senior leaders don't. Many of them weren't clinical to start with, and they've got a different purpose. Their purpose, in a way, is they've got these large organizations, and the organizations are challenged as well. There's so many different regulations, financial things happening, all of that. And their job is really to take care of the organization. It's to make sure the organization is healthy and viable. That's not our job as doctors. Our job as doctors is to take care of the patients. And at some core level, taking care of some organization to keep it all healthy and going may be a connection there. There is a connection there, but most people don't see it. And so the senior leaders get frustrated that the doctors who used to be independent are now employees, don't act like every other employee and just do what they're told. And so we've got to cross this divide, because all these brilliant people, if they were working together, could do amazing things. And that's kind of like what we ended up achieving at Sutter Gould as CEO. I deeply connected with my docs and the rest of my staff, and that helped us to do that.
Yeah. It's certainly good to be, like you said, recognized for, like you said at the beginning, the doctors have knowledge, they are leaders, they're not just employees, they have a level of responsibility to their patients and their staff, and it's nice to have that acknowledged by above. It feels so loss of power if somebody's making decisions above you and you're like, that is such a stupid decision. Like even the design of the building or the type of software they chose, it's just like, yep. How did you not see this would be a problem kind of thing? But you're right, it's big, hairy problems, because until you put something in place, you don't see how it's going to affect the other cogs in the wheel. I'm so fascinated to understand how you were able to disseminate this information to such a big organization, because we know that physicians are busy, clinicians are busy, everyone is already busy, and things like even putting a meeting in the middle of a day is going to disturb the other, like it's going to add to the workload, because the things that normally get done in that time now have to be put somewhere else. How on earth did this all start to be given out as an organization vision?
Yeah. So really you're asking, how do you lead transformational change? And fix the plane while it's still flying in the air.
Well, it's still flying. That's right. We can't just, shut it all down for 6 months and let's get this working better.
Right. So there's multiple components to how to do that. One is starting with getting clarity about what we're trying to do and have everybody understand what the vision is. And we may have a vision that we haven't figured out exactly how we're going to get there yet. But if we're committed to that vision and committed to each other, and we then, will work hard and cut each other slack when things don't go exactly as planned, that can help a lot. Secondly, identifying one pilot program location to start to do most of this work in the first time, to work out the bugs and the kinks and give that place a little more leeway and breathing room. So we can do a lot of the changes that we did in this one internal medicine office. And we did, stepwise things like redesigning the front desk, simple things about ways to help patients figure out where to go, wayfinding. We developed worked on the in-basket and helped manage the in-basket more effectively. We created team care approaches to medicine. So we actually had a medical assistant prep the patient as much as possible before the physician came in the room, and then stayed in the room and acted as the scribe before AI scribes were available and did the job so well. But we had to test all those and then gradually spread them to the other offices. We had a large, 300 doctors. We probably had 40 different offices, 30 some specialties. Whatever got developed in that test office, the concepts could certainly get spread to other offices, but the specifics had to be adapted because the neurosurgeons that don't want exactly the same workflow that the internist wants, right?
Yeah.
And so to do that, one of the key things we did was we developed daily huddles in each office that were 15 minutes long, and that had at least 4 key components in them. One was a minute of acknowledgement, thanking somebody on the team, thanking somebody else for something they did that helped them the day before, just to build that positivity. Second, to prepare for the day, look at our capacity and demand issues. I mean, we may not have all the staff, equipment, and supplies we need for what's coming at us in the schedule or the census, but at least we know at the start of the day and we can adapt and prepare. Third was looking at metrics, and we just did 1 metric a day and looked at our performance on it. If it was great, hey, pat ourselves on the back and move on. But if it wasn't, then we start to think about how do we solve the problem to get that back on track. And the fourth step actually is problem solving, whether it's a metric or one of those little pebble in your shoe kind of problems that drives you crazy. You open up a drawer and what you need's not there, or something like that. Every time it happened to me, I would get frustrated and stomp around till I got what I needed and then swear I'd never let it happen again. And forget, but before I got a chance to talk to anybody about it, I forgot about it. And then until the next week when it happened, and I was even more frustrated. And instead, when those little things happened, we put them on the huddle board for the next day. The team would look at it all together and said, oh yeah, that's a problem for all of us. Let's come up with a little solution to that. So we could gradually fix little pebble in your shoe type problems. And the huddles could also help us adapt a new process from the model unit to fit and work in our unit. So we have a model unit where we do the deep redesign. We adapt through huddles to incorporate it into the other offices. And so in that process, we really could make it happen well. We also found it was very helpful. In most groups, if there's a doc in a leadership role, people want that doctor to be seeing patients because then they know that you're feeling, if my physician CEO is seeing patients, then they're feeling my pain of the EHR. And there's validity, it's absolutely valid. But I found I didn't have enough time to work clinically regularly and do that job effectively, especially because I didn't already have a panel of patients. I came from outside the organization, everything was brand new. And I tried, but I just failed. And so instead, what I did was I took that same time I would have used seeing patients and I shadowed different doctors in the group. And so I would go to every office, go to every different specialty, spend 2 hours or so just following them around as they were working, observing, learning what worked for them, what didn't, building relationships, which also helped people to accept change more. And so all those things contribute. it's not leading change is not it's not easy. People, in fact, one of my favorite quotes is from Machiavelli, um, who said that one of the most dangerous things to do is to introduce change to the natural order of things, because the people who are benefiting from the old way will fight you tooth and nail to
Hmm.
not lose
Hmm.
that. And the people who are going to benefit from the new way, they haven't really, they're not going to be such strong supporters at first for two reasons. One is they haven't experienced it yet to feel it viscerally and say, yes, I'm going to fight for this. And second, the people that are clinging to the old way are fighting so hard that the people trying to improve are saying, I don't want to deal with it. I'll just suffer. So it really takes a fortitude of the leader, and you can't just do it as a sole leader. You've got to build a group of people around yourself who share your vision, and then together as a group you can do that.
Hmm.
And that's really key as well. It can't be a lone wolf trying to drive it. You've got to build the coalition and really help that and help it lead that way.
Hmm.
But we would have, and then it's not just the physician CEO who's going out and shadowing, but everybody on that leadership team should be out there. Even, the quality people, the chief financial officer, the chief marketing officer, the more they go and shadow and watch what's happening in the clinics, the more they realize, oh, we do need to invest in improvement. We do need to, this is worthwhile. It's going to make a difference.
Hmm.
Actually, some of the people who fought when we first started huddling, we didn't insist the doctors join the huddle because we were still learning and we wanted to make sure
Hmm.
it worked well before we asked them to give up their time to do it. And there was a lot of fear like, oh, they're going to just come to us and say, you're telling me you want me to be more productive, and now you're telling me you're taking away 15 minutes for me to see a patient. Um, what we found though was the huddles helped the workflow of each day become so much better that the offices where the huddles were working well were far more productive than the places where the huddles weren't happening, uh,
Hmm.
or weren't working well. So it's a small investment, but it has a huge return on that investment, a huge value as a result.
Yeah. Okay. Interesting that um, by slowing down to
Just a
do a
little.
huddle,
Yeah.
it can help the vision, the acceptance of change, the understanding the why behind why is everything different this week compared to last week, and
Yeah.
to
Yeah.
help the whole team come together and understand, even hearing that appreciation of one team member to another, helps us all as a collaborative team. I can understand that.
Yeah. Yeah. Yeah, actually, when you stop and think about it, a huddle design like what I described addresses all six drivers of burnout. It addresses the overload, it addresses control, it addresses appreciation. People come together as community. They feel things are more fair because they have a chance to actually, they're working together. And you can see the values alignment through paying attention to the metrics when they're designed
Mhm.
well. So
Yeah.
I had no idea as we got started just how much power there was in this. It's only in retrospect, looking back, you know, I was no genius. I'm no brilliant leader, strategic guru. It's just a matter of taking these principles and gradually putting them into place with some good guidance. The other thing is, we hired a firm who had experience not at making clinics more efficient, but at teaching people who are working in and leading the clinic, how to do this problem solving and how to develop the efficiency themselves. It's the old, teach a person to fish, not give them a fish kind of thing. Yeah,
That was going to be my next question is, did the team who came in to the improvement team say, here's how to run more efficiently, or did they come in and say, what do you notice needs doing better? And I
exactly.
think you just answered that for
Yeah,
us. And I think that's so important because when I've seen improvement done during my clinical time, it's typically been, here's what you need to implement. And it's like, you don't understand how busy I am already.
right, right, right. Yeah. No,
Rather than, what are you noticing isn't being done well that we could be doing better? That is a totally different question
yeah.
than, here's what you need to do.
Right, right, exactly. It's not, if somebody does it to you, it doesn't work. When somebody does it with you, then it works. And the other thing in our model, in our model cell, model unit, as we were doing these improvement work, we would have people from other offices come and participate on the teams. So they could see it, they could and help us understand what would work, what might or might not work in their offices when they brought it back. And they could also help build momentum for when the changes were coming, that people were excited about it.
Mm,
You know,
yeah,
so we
that's
couldn't
clever.
do it. You can't be completely isolated with the
Yeah.
models, have somebody go off to somewhere. Oh, we're the innovation team, we're going to go off, somewhere and nobody's going to, nobody gets to see what we're doing until we come back and present you the
Yeah.
solution. That's not,
Yeah.
that's not the way it works.
Yeah. Yeah. That's what I love about this work is helping the physician to identify for them what could be helpful, and they start making those micro changes for themselves. I'm kind of more of a starting with one and they kind of spread out their team, whereas you've come from the top and said, we don't want to impose on this team. We want to help them be empowered to do what they need to do, which was
Yeah.
a huge feat, I think, to be able to do that.
Yeah,
Um,
that's what actually I loved about what you're doing with the whole concept of really charting more efficiently. I think that's a lot of your focus because for me that resonated deeply back when I first, I grew up in paper records, right? And I had a shorthand all figured out. I could write a note in no time at all. And then we got the EHR, and it was like, oh my gosh, how are we going to do this? And there were so many nights I fell asleep on the keyboard trying to get my notes done. Um, and and it became clear that we needed a different way. But
mhm,
still, then I was in N01 trying to figure out how to be more efficient, and I'd figure out the smart sets and change the way we're doing things, and tried to help others do that just at in baby steps when we were first getting started.
mm,
But having that, it's all what you develop. I think in Lean, we call it standard work. It's like, this is a process. We develop it. Once it's working, we're still going to improve it. It's only the standard work is only the best way we know how to do it at the moment, but we're always identifying something else that's wrong that we can tweak it a little more. So
mhm,
standard work is not, it's not frozen in place. It's constantly dynamic.
mm. Now, tell me about what you might have seen in regards to the model you've demonstrated shows a lot about what do you need, what are you identifying in the system's not going well, but what about at the individual level, at that, what do you need to be successful today? Whereas some physicians might need, for instance, a desk modification for their height.
Mhm.
Some physicians might need quieter surroundings because they have hearing issues. Some physicians, or even our staff, some are going through quite significant home problems and they're really super stressed. So it's very hard to do that high level work at work, and they may need to transition into other roles for a while where it's not as taxing on their executive function.
Yeah.
How was that played out within the organizations? Was that something that was factored in, and how was that addressed?
Yeah. So, wow, good question. I see it as at its core, it's coming back to that concept of respect for people. If and in almost all of these cases, it's not the cost, the cost, oh my gosh, the cost for a doctor to have an elevating desk. My desk, the desk I'm sitting at right here, I can stand. I have it in my own home, but I couldn't imagine not having it. And we are the highest, we're the highest trained, and in our organizations, usually the highest paid professionals. And in any other industry, when you take somebody and we're the only ones that produce revenue. In any other industry, when you take people like that, you would never have them doing the lowest level secretarial administrative work, like typing notes into the like keyboarding, you just or running around and finding stuff or anything that they don't, you want to maximize the value of that person, including maximizing their physical capability to do the work well. And it's different for each person. We found that actually when we developed our offices so that the doc and the team could sit together and view their own exam rooms right from all one spot, that we really didn't need the same number of doctor's offices anymore. We built a doctor's lounge with some private study carrels, and that was more than adequate for what people needed. Um, and in fact, everybody was getting out earlier and getting more work done because they weren't going back to their office and hiding. And it was hard to accept at first. In fact, I had to. There were very few offices around the country. There were very few places that were actually doing this when we first introduced it. And I wanted my doctors, a key number of physician leaders, to see it so they would buy in and be supportive. And if there was something wrong with it, I wanted to know before we invested in it. So we had to go to like the middle of Missouri, somewhere near St. Louis, to get there. And we were in the middle of Central Valley, California. So the choice was to either spend 3 days of travel back and forth and 1 day there, and the docs would have lost huge revenue. And probably some of them would have had family problems and everything. So instead, we chartered a private plane and got up early one morning, flew to actually this small town near St. Louis. When everybody went in, we'd spent 4 hours at the place, got back in the private plane and flew home, and lost only 1 day of productivity, got huge buy-in from all the docs and support staff to be able to come back, share their visions. And and it paid off in droves. And it's right, but it also appreciated the professionalism of those physician leaders who were going to be there and needed to have that input in order to make it happen. So yeah, so elevated desks. Some people do need, there's all sorts of accommodations people need in order to function well. And we still have our amazing, brain power, empathy, everything that we do to serve patients, that we want to facilitate that, not limit it.
Mm-hmm. Yeah. I'm still seeing cases where the physician is wiping everything down before they go get the next patient.
Oh
Like
my God,
literally still
no,
in the world, there is
no.
that model still happening.
Oh,
And they're asked to do more, do more, do more. And so I'm really grateful for these conversations and for these start to notice. Everybody working toposcope is very helpful.
yeah. Well, and really help. This is where shadowing is so important particularly for non-clinicians, because if they go and see that, and then they have any business sense at all, they'll realize. I was at one hospital, gave a keynote to the medical staff, to the medical exec, to the C-suite, and the C-suite afterwards, the chief strategy officer asks me, he says, "Well, this all sounds really good, but we're already losing $125,000 per doctor each year. You think I can afford to invest another $25,000 or $30,000 per doctor?" And I just wanted to ask him, so that formula you've got to figure out how much you're losing per doctor, what is it? It's the revenue the doctor produces versus the cost of supporting them. Can we apply that to your salary? How much revenue do you produce, strategy officer? And what's your salary and all the support it takes to do? I think you're doing worse than they are. Maybe who's the right person to be supporting here? They lose perspective. They forget. It's all about one of the ways to think about leadership and management in particularly in these large organizations, is the most important person in the healthcare system is the patient. Without a patient, we have no reason to come to work. We have no money coming in to pay us and support ourselves and all of that. The most important thing that happens to that patient is a healing interaction that takes place between and it's not just the doctors, it's the nurses, it's receptionists, it's transport people, EVS people. Anybody interacting with the patient can reduce some anxiety and worry, relieve some pain and suffering, educate people to be healthier. Those healing interactions happen hundreds of thousands, if not millions of times a day. That's what matters. And as I stopped seeing patients, as a family doc for 25 years, probably had 100,000 healing interactions. When I was CEO, I wasn't seeing patients anymore. I wasn't doing the most important thing for the most important person in my organization. My job was to make sure that those people at the front lines had what they needed so they could do that well. And that's the job not just of the CEO, and my job is really to make sure that the people reporting to me had what they needed to help support the people on the front lines. But the CIO, the CFO, the COO, their job isn't to protect the budget of their department. Their job is to make sure that those people on the front lines have what they need to do that so well. It's like there's still places where people are typing in passwords, and it drives me crazy. Instead of being able to just do a little recognition, whether it's something biometric or a little card, some way to just do the password quick and keep moving. Um, and they thought, well, this is going to cost too much to put in this automatic recognition. It's like, really, have you thought through the metrics of that and realized what difference it actually makes? And these folks who have the power to make these decisions don't really experience the downstream impact of their decisions, and that's why it's so important that they shadow. And that makes it important for clinicians to invite them to shadow, because quite often, we've gotten also cynical as we've gotten burned out. It's like, oh, fine. The CEO wants to come and follow around. Good luck. I'm not going to do that. No, you need to. This is your opportunity. Yeah, it's going to be weird at first, but it's if you open the door warmly and welcomingly, you're going to build a relationship, and it's going to be a lot easier to get that biometric device to make your day goes better when they see that. So.
Mm-hmm. Yeah. Were patients part of the change innovation assessment? Like, did you have patients as part of that, or was it expected that you knew how to improve quality of care for patients because that's what the staff focus on?
You ask a lot of really good questions, I have to say. So yes, in theory, in pure lean, the customer should be on the team that's doing the redesign work, because and in healthcare we can say, well, yeah, we're all patients too, so we can be the customer. We can be the patient, we can represent a patient as well as we represent all the workers. But we know it's not really the same as you come from completely outside. What the challenge for us was finding patients who could give up enough time to participate, because usually these big redesign events were 3, 4, or 5 day events. And the kind of people who could step out of their personal lives or their own other jobs to spend time with us was pretty tough. There we could find a few, but it's a lot. It's a big ask, especially for a lot of folks. So we would always try. Sometimes we succeeded more than others. We would also do things to, try to certainly to get information from the patient before the event started. So we want to gather a lot of good information to understand what's the current state. Where are we at right now? Because really what you're trying to do is say, here's what things are like now. Here's a goal, a vision, a future state we want to move to. And then you go through this intricate process of looking at the gaps between the current state and this future state, breaking it all down into the deep individual root causes and coming up with solutions to address those root causes. At least if we start with a good understanding of what the patient is experiencing, feeling, then if we can't get a patient on the team to help guide us, at least we've got that to start with. And then maybe bring patients in, as we're finishing up. The other thing we found sometimes, particularly if we're making a change in a particular unit, not everybody in the unit can be in every team every time. But we would at least make sure the manager and the supervisors in the unit came in at the end of each day, where we would report to them where we were in the process of designing our changes, to validate with them, yes, okay, you guys, this is what you're thinking. Yeah, that makes sense. Or I think you're kind of missing this. Go back and check on that thing before you get yourselves too far ahead and realize you're not getting it right. So it is really important to stay in touch with the people that you're going to impact. You can, yeah, there's a new team doing it. Yes, we all were, somehow involved in the process. But if we're going to then go back and tell this other group that, we figured it out for you guys, you're welcome. They need to be engaged in the process along the way as well.
Mm-hmm. With the huddles during the change process, do they continue now, or is that just something as change is
Yes.
starting and getting started?
No, in fact, we had one place we were going in to consult with them, and everybody's so short of staff these days, right?
Mm-hmm.
You know, and we thought, well, they wanted us to redesign a pretty good sized primary care clinic. In fact, it was the one where the CEO's wife got her care, and it's like, let's go there, we'll redesign it, it'll be great. Well, we got there, we'd explained to them what it was going to take to do the redesign, and they said, no way, we do not have the staff to give
Yeah.
up to do this work. So we decided, what we can do that's low impact is just start huddles. And
Yeah.
so we spent a week designing the huddle with the team designing the huddle. We didn't just come in and say, here's what to do. We had good concepts, but we wanted to make sure it fit their needs. So we designed the huddle for a week, then we launched it. And we had an agreement with this organization. They had at least 100 outpatient offices. We said they gave us 3 months to introduce huddles to 6 of the offices as a pilot project. It took off so fast and it was so welcomed that by the end of the first 3 months, we were in 14 offices. And 15 months later, we were in all 100 offices. And people were calling us up saying, we just want the huddle board. We'll put it up and we'll do it ourselves because we've heard such good stuff about it. It's like, no, yes, you need a board to organize around as you come together, but it's a process. You have to learn the process, otherwise it won't work. But once it got spread, it turned out that first office, they went from a 40% turnover of their support staff to zero turnover the first year in their support staff. In fact, a week after we started, one of the medical assistants came to the manager and said, I was ready to quit. I actually had another job offer. I was ready to leave. And you started this, and I thought, this is interesting. And it seems like people care about me, and I'm going to actually have some say around here now. I'm going to stick around and see what happens. And she became one of the real stars in that office. So it's this whole thing and that huddle in and of itself is very powerful. And then we also can build them so the frontline huddle can be followed by a huddle where the office manager huddles with directors, and then the directors huddle with people up in the C-suite. So you have these we call tiered huddles, and whatever needs to get communicated for extra support or help, or to be sure people are understanding what's happening in the organization, that communication happens through those tiered huddles. And then that really helps the whole organization function better. And it actually makes it much more responsive and adaptive to changes happening in the external environment. And oftentimes people will look at me when I present this and say, oh, that sounds great. Good for you, Paul. You can, maybe you made it happen where you were, but there's no way our organization would ever do that. And I'll just ask them, hey, did you ever, do you remember that thing 5 years ago called the COVID and the pandemic? Remember how every hospital had a command center that met 2 or 3 times a day to get information from the front lines about what was going wrong? And if somebody figured some solution out, they would communicate it up and we'd spread it all around and make sure everybody got taken care of. And we responded as quickly as we possibly could because there was this true existential threat and people's lives were at stake. It's the same thing. It's just, there's still a threat. There's still all this stress. It's maybe not life-threatening, like we need to meet 2 or 3 times a day, but we have a way to respond quickly to these changes happening around us. And we've just forgotten about it so quickly after we've found it worked so well. It was too intense to keep going. You can't do 2 or 3 times a day. But most places, the places that are really going to win, will do this once a day. It creates a strategic advantage where the entire organization can rapidly identify and respond to external changes. Places that do it 2 or 3 times a week are going to be way ahead of those places that do it once a week or that have stopped doing it altogether. But it's a huge strategic advantage, adaptability. It's what Darwin said, right? The key to being strong, smart, or having market share or money, the key is to be able to adapt rapidly to external change to survive.
Very interesting. Well, thank you. I really appreciate this conversation. I think it's going to be very helpful for so many people who are struggling. Where do people reach out to find you? Where are you found?
Yeah, so I have my website is pauldechantmd.com. My email is paul@pauldechantmd.com. I'm also on TikTok, so you can find me there. I do a lot of work. Right now I'm trying to help support managers who are struggling, caught in the middle. But I've talked a lot about burnout as well. Managers burnout. Everybody's got these drivers of burnout are universal. And I'm on LinkedIn, so people could find me there as well. But yeah, website, TikTok, email directly. love to talk to anybody about this. It's my passion, as you can kind of tell. Uh,
I can, absolutely. Is there anything we didn't talk about that you wanted to mention before we close for today?
oh, probably an hour's worth, but we'll do that another time. No, I would just wrap up by thanking you for doing it. I'm so impressed. You're doing this podcast so regularly and getting it out. And I've just seen so many people I know, Steve Beeson, Kristen Olson at Corewell, Diane Shannon, my co-author, just a whole slew of great people that I know that you've had as guests already. Your this message so wonderfully. I really appreciate that.
Yeah, well, I have a whole listenership who is trying to make life sustainable in their career so they can have a life outside of medicine. And so the more experts we can find in the world to help us with different ideas, knowing that there's infinite possibilities to improve
Yeah.
sustainability is so important. So thank you so much for this conversation.
Well, I'll give you a couple others once we get off the podcast.
Sounds good. We're looking forward to hearing from more people. All right, have a great week, everybody. Thanks for listening.
Take care. Thank you.
Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast, and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have charting champions for physicians and smarter charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.